Hello people, welcome to another edition of Research Night. Like you know, Research Night is a public event that is held across 30 European countries and actually 300 cities at the same time. And the main aim of Research Night is to present research and innovation to you in a more fun way. Today and this time around is coming to you in a virtual form because of everything happening with the coronavirus pandemic, but we hope that you have a wonderful time. Thank you. So my name is Kwakye Nomah. I am a Ghanaian and I have a background in medicine and global health. I'm currently a PhD candidate working with the Center for Epidemiological Studies on STIs and HIVs in Catalonia, and also with the Autonomous University of Barcelona. Today, I present to you characterization of COVID-19 among people infected with HIV/AIDS. The potential effects of COVID-19 or SARS-CoV-2 infection among people living with HIV is currently not clearly understood. Earlier reports from the CDC reported that people living with HIV who have a low CD4 cell counts or who are not very active on their antiretroviral therapy could be at risk of severe outcome from COVID-19. These reports were buttressed by recent large studies actually from London and from South Africa. But other researchers have argued that there is a possibility of protection from the antiretroviral therapy like protease inhibitors and tenofovir. In this study, we will be presenting to you the epidemiology, the clinical characteristics and outcomes of SARS-CoV-2 infection among people living with HIV in Catalonia, Spain. We performed an observational retrospective cohort study using the PCIS cohort of HIV positive patients in Catalonia. The PCIS cohort is actually a cohort which has almost all patients who are infected with HIV/AIDS and are in care in Catalonia. We linked patient level information with the PADRES. The PADRES is the data analytics program for health research and innovation. In the PADRES, we are able to have information regarding hospital usage, that is overall hospital usage, including admissions, primary health care, and pharmacy. How did we define COVID-19? To define COVID-19, we had two key ways. So we had the clinically diagnosed patients and we had the laboratory confirmed patients. For laboratory confirmed patients, these were patients who had positive PCR test or serology antibody test. And for patients who were clinically diagnosed, they were patients who had clear signs and symptoms, very compatible with COVID-19, but didn't have a PCR or antibody test. But these patients were still diagnosed with COVID-19 according to the ICD-9 and ICD-10 codes. We excluded all patients who died before March 1st, 2020. Socioeconomic status was classified according to the index that is created by the AQUAS in a tercile. So the first tercile were the people of high socioeconomic class, the second tercile were the middle class people, and the third class were people with low socioeconomic class. For comorbidities, we only reported comorbidities which were prevalently high in our population. To define comorbidities, we only selected patients or we selected cases which were diagnosed by doctors in the hospital or patients who have received pharmacy for chronic comorbidity, or if this patient was living on a supportive device for a chronic disease. Severity of cases were classified according to asymptomatic, that is those without symptoms, mild, those who had very few symptoms and were not hospitalized or were admitted at emergency for less than 24 hours. Then we have severe cases, that is those who were in hospital who had hospital admission for more than 24 hours but were not at the ICU. And the critical cases were those who were admitted at the ICU, and also we had, of course, those who died. Follow-up period was between 31st January 2020 to June 23rd, 2020. For our statistical analysis, we basically performed a descriptive statistics analysis. Significance of p-value was set at 0.05. And also we had a latent class analysis for comorbidities, grouping into 3 key groups. The Venn diagram here shows the COVID-19 diagnosis notification sources among people living with HIV in Catalonia. From here, we understand that the majority of the notifications came from the primary health centers, which are also referred to as the CAP. As of June 23, 2020, 452 out of the 10,464 people living with HIV in our cohort had been diagnosed with COVID-19, representing an infection rate of 4.32%. The infection rate is higher than reported rates from cohorts of HIV, COVID-19 co-infected patients from Milan, from Bologna, Madrid, and Wuhan. This comparison should, however, be interpreted with caution because of the lack of information regarding testing intensities from these studies. For example, in Spain, at the beginning of the pandemic, only symptomatic patients were tested. The infection rate notwithstanding could possibly somehow reflect the overall situation in Spain. The recent any COVID study reported a seroprevalence of 5% in the general population. Of the 452 diagnosed patients, 68 were hospitalized, 5 were admitted to the ICU, and 9, that is 2%, died. The mortality rate of 2% is, however, lower than reported mortality rates from the general Catalonia population and from other cohort studies. The low mortality rate in our study can be attributed to the fact that our cohort is generally younger compared with other cohorts, and secondly, almost half of co-infected patients were without comorbidities, which have been identified as major risk factors for COVID-19 severe clinical outcomes. In this table represents the sex and age distribution of the members of our cohort. In line with reports from previous studies and the general population, patients with severe or critical outcomes and deaths were older compared to other co-infected patients. To round up socio-demographic characteristics, the table shows place of birth and socioeconomic status. As reported in the general populations, the proportion of co-infected patients who belong to the third tertile or lower socioeconomic group was higher. The COVID-19 pandemic has highlighted the existing inequalities in populations around the world and emphasizes the need for key stakeholders to take the necessary actions to bridge these disparities. This table shows the HIV-associated variables. Previous studies suggest that a high viral load and a low CD4 cell count might restrict COVID-19-associated immune dysregulation and the development of a cytokine storm. In this study, however, we observed low CD4 cell count among patients who experienced adverse outcomes. This is inconsistent with the hypothesis that the absence of T-cell activation could reduce the severity of SARS-CoV-2 infection. Comorbidities such as hypertension, cardiovascular disease, and lung disease have been identified as major risk factors for severe outcomes from COVID-19, and these were very prevalent in our population. Regardless of the relatively young age of our cohorts and the lower prevalence of comorbidities, majority of patients who experienced severe outcomes and death had at least one comorbidity. We use latent class analysis to explore the multi-morbidity patterns. 11 groups of the most prevalent diagnosed diseases were included to create different latent class profiles. 1. Generally healthy, 2. Cardiorespiratory and metabolic disease, and 3. Renal and liver disease. In the graph, we observe a majority of our population being generally healthy. The next line of action in our study will be to look at how these latent classes contributed to COVID diagnosis and clinical outcomes. Information regarding the therapeutic effects of antiretroviral agents against SARS-CoV-2 infection is currently inconclusive. In our cohort, we observed no significant differences between antiretroviral therapy being received by COVID-19 infected persons and the uninfected population. Additionally, the distribution of antiretroviral therapy regimens was similar among co-infected patients regardless of the clinical course or outcomes. In conclusion, the epidemiological characteristics, clinical features, and outcomes of COVID-19 were comparable to the general population. People living with HIV who have lower socioeconomic status were more affected. Comorbidities in our population were lower due to the relatively younger age of our cohorts, but were more prevalent among patients who experienced severe outcomes or death. there was no evidence of the possibility of protection from any antiretroviral therapy. Patients who experienced severe outcomes and death had the least CD4 cell count, speculating a possible association with disease severity. Further research will be imperative to establish an understanding of how CD4 cell count, comorbidities, and antiretroviral therapy contribute to the clinical course and outcomes of SARS-CoV-2 infection among people living with HIV. Thank you, and do well to subscribe to this channel.